Okay, good morning, afternoon, evening, night, wherever you are. It depends on which part of the world or which part of the planet you're on. But welcome to everybody. My name is Shakareshi, for those of you who don't know, and I'm joined by my co-moderator, Mark Gavilic from Belgium. Everybody knows him very well, and we've got a fantastic team joining us tonight. I'm grateful also to Venusmedtech team for organizing and coordinating this webinar symposium. Etty in particular has been very good in discussions and arranging the program. This is a case exchange online meeting, as we call it, where there's an opportunity for discussing, presenting venous valve, different types of cases. We've got some experts who are going to do that. These are challenging cases. And then the wider issues of what sort of anticoagulant, antiplatelet treatment may be required, and then the longer term follow-up, and then what happens in the future. So that's the sort of plan we have this evening. We've got some fantastic speakers. Before all that, I'm going to ask David Briand to say a few words. So David, you're on next.
Thank you very much, Shaq. So good afternoon, everyone, and welcome. So my name is David Briand. I'm Vice President for Venusmedtech for the international region. So on behalf of the team, it's a real pleasure, let's say, to have all of you, let's say, joining us today. And thank you very much, let's say, for taking some time to be with us. So as you know, since April 22, when the Venusp received CE mark, we have seen a continuous expansion in the numbers of centers and physicians using the device, with very strong clinical adoption, but also highly encouraging outcomes. So this growing experience across multiple regions is a clear reflection of the trust you place in our technology and in our team. So today's meeting is part of our ongoing commitment to education and share learning. So our objective of today is really set to create an open and interactive forum where we can discuss real case experience, challenge, and
David, you are muted.
So once again, I'm not going to say to take too much time. So I want to say really to thanks all of you to join today. I want to thank the physician that have prepared, let's say, and present the case today. So we are really looking forward to a very educational and interactive section. Once again, thank you to be there, and I will give now the floor to Sir Shaq and Mark, who will guide us, let's say, through the session today. Thank you very much.
Thank you very much for those words. Can I just request all the attendees and all the speakers, if they're not speaking, then they should mute their speakers, please, because otherwise we'll have a lot of noise, and that makes it difficult for us. So what else? We want this to be interactive, and so if you could, in the chat box, raise your hands, and then somebody will pick up that there is a question, and then we will ask you. I think you can see the agenda in front of you, and so I'm going to ask my friend Mark Gavilic to do the introductions of this first speaker.
Well, the first speaker is Maria del Cerro from Spain, from Madrid. And I think she has a very interesting case for us to present and then to be discussed. Maria, the floor is yours. Maria?
You're muted, Maria.
Yeah. Are you seeing my screen?
We see a screen. I think it's yours. Yes.
Yes. So, sorry. Thank you. First of all, Good afternoon, everybody, and thank you for inviting me to learn from everybody and to share this case that we performed in Madrid like 1.5 years ago. The patient was a female, 36.
Maria, we see
Maria?
Yeah.
the wrong projection. I mean, you are not in projection area. Perfect.
Yeah, thank you. The patient was a female, 36 years old, diagnosed in the neonatal period of severe pulmonary stenosis with a small right ventricle and a coronary anomaly with a common origin of the right and left coronary arteries from the right coronary sinus in the aorta. The patient needed neonatal surgery with valvulotomy and surgery augmenting the right ventricular outflow tract that was really small. And she did quite well until the age of 36 years. The patient was at this evaluation asymptomatic with a good cardiopulmonary exercise testing, peak VO2 of 78 predicted, no significant arrhythmias in the CPET, only ventricular extra beats in the holder. The referring physician insisted in that her right ventricle was progressively dilating. The left ventricular function was decreasing with a severe pulmonary regurgitation with regurgitant fraction of 42% and progressive increase in right atrial size and progressive increase in also intracuspid regurgitation. So we performed a CT scan to be evaluated. The diameter of the trunk was quite tubular, 33 for 34 millimeters, and the length from the annulus to pulmonary artery roof was 54, and the distance from annulus to bifurcation 40 millimeters. This is a very nice reconstruction by Dr. Phuoc Duong, and she made this reconstruction, and as you can see here, the anatomy was good for a venous valve, except for the left coronary artery surrounding the whole circumference of the right ventricular outflow tract exactly at the annular level. And as you can see here, the distance between the left coronary artery and the annular level was measured as 1 millimeter, 1.8 millimeter. And in the nice evaluation by Dr. Phuoc Duong, this was exactly the most easy point for the landing zone. As you can see here, at the valvular level, the diameter of the annulus was between 30, 28, and for a supraannular, it was quite wider, the pulmonary trunk, and with a very wide infundibulum. It was categorized as an amber 2 due to this anatomy. So with this, taking everything into account, what do you do with this patient? Would you proceed with PPBI or just let the patient with clinical follow-up? Would you send the patient for surgery, proceed with another model of percutaneous valve, do a Venus P depending on the balloon interrogation, or just think only if Venus P, if supraannular implant was feasible? You can scan the QR code with your cell phones and answer, and I will stop sharing the screen.
So whilst Maria is waiting, if you could answer this, actually, if you bring back your screen and the questions for us, just for the other slide, if you could. Oh, all right. We'll go live with the voting then, because I was going to ask, from the CT scan report, Fu was given possible options of sizes, and if you had to pick one or two at most, which size would you pick to have available? So that was going to be a question really for the imaging person, if Fu was available. But the audience, I think, are answering your question. So carry on, Maria.
Yeah, so I will share my screen again, and I can go on with the presentation. So what, of course, the Dr. Phuoc Duong evaluation showed different possibilities for supraannular and annular level, and it advised act depending on the balloon interrogation. So sorry, that was what we did. So We performed the coronary angiographies to confirm the anatomy and to exclude any other problems in the coronary anatomy. You can see here the right ventricular outflow tract angiographies.
Yeah. So Maria,
Yeah.
Just let those keep playing. And I was going to pick on Francisco. If Francisco, any thoughts on what you've heard so far from Maria's data before this, and the CT pictures, and now this angiogram? Any thoughts on what would be your method of decision making?
I'm agree with most of the people that, from the anatomical point of view, I think it's a good case for Venus P. The main concern that Maria has is the coronary artery curve, but I think it's all depends upon the balloon interrogation and see if the coronary has a kind of compression.
And so you'd be looking at transannular or supraannular implant.
I think we could not avoid to catch the pulmonic valve annulus.
Okay. All right, Maria, carry on.
Okay. So, of course, we performed the balloon interrogation, and you can see here that the only waist was at the annular level, with a waist between 27 and 28, and the balloon was stable at this level. And we did a coronary angiography in several different projections to be sure. And we couldn't see any compression with a 34 millimeters AGA balloon. So after this balloon sizing, what would you do? You can vote now if you would send the patient for surgery, if you implant a Venus P at annular level, if you would implant a Venus P at supraannular level, or if you would proceed with another PPVI model. And I will stop sharing my screen.
Okay, so very important decision making to be done, and people are answering. Just based on what you've seen again, Francisco, what size venous valve would you be looking at?
I think 30 millimeters diameter should be good. It's a slightly oversized, for sure not to proceed with an extremely higher oversize. 30 millimeters could be.
Okay.
Okay.
All right, carry on, Maria.
Yeah, I will share my screen again. And of course, I did as Francisco said. Sorry, I can advance the slide. Yeah, we proceeded with a 30-25. We left for safety a guiding catheter in the ostium of the left coronary artery, and we left a coronary wire in the left coronary artery. I even went to the adults cath lab that is next to our cath and said, okay, if I have any trouble, I will call you. And they were kind of on call for us. And the delivery was without any problem.
So Maria, did you do the selective coronary wire intubation yourself, or did you ask an adult cardiologist to help you?
No, we usually do this. In regular cases, we do this just to feel safer. In this particular case, in where the full left coronary artery was on risk, I just wanted to be sure that we had backup and not. And the guy said, "Okay, if you have any trouble, you call me." It wasn't needed, as you can see here. we were injecting smoothly during the deployment, and we didn't have to do anything. After finishing, we confirmed the left coronary artery was okay in several projections.
Yeah, Maria, one question from my side.
Yeah.
You said you had, and especially on this slide, you said you had a coronary wire in the left. But which stent? Did you have a stent available? And if yes, which stent? Because if this is going to be a stretch, I mean, you're going to need a very, very, very long stent. Do you agree?
Yeah, absolutely. That's why in this case, I had a lot of stents on the shelf, and I had a coronary specialist by my side, I mean, in the next room, because I thought I wouldn't have any problem with the coronary because the balloon was quite clear, the interrogation. But I was also afraid not just of the compressing here or in any point, but distorting the coronary, the aortic root, and causing distortion of the left coronary ostium. So I was concerned not just at this point or this point, but also sometimes a large venous can distort and displace the aorta, and a coronary ostium can become smaller. So I had several coronary stents available and also a specialist in case we had a problem. But he came to see the balloon and said, "You are not going to have any trouble." So, thank you very much. So we proceeded, and as you can see here, the left was perfectly filling. So we removed the coronary wire after looking at these images. The patient had no other problems, and at the follow-up, the patient had a normally functioning pulmonary valve. The right atrial size decreased very, very rapidly. And at 6 months follow-up, we did routinely perform CT scan in our patients. You can see here the position of the left coronary artery close to the stent. The patient had some Hall syndrome in the leaflets. In the spiral fact, she had been left with oral anticoagulation. But as the valve was with a normal function, we just left the patient for some more months. And this is the whole image of we couldn't see any fractures of the stent in the CT scan. And you can see here how the coronary was surrounding the venous stent, but without any interaction, and how the aortic root was also preserved. So I chose the annular implant because I felt it was the smaller venous that could be fulfilling this patient anatomy. I tried to not oversize, and I was scared of doing a supraannular implant and distorting the aortic root. Sometimes we worry about the coronary here and forget that the coronary root is also important, especially in these cases in which the ostiums are not in the standard place. And this is all about my case.
Okay. Maria, thank you very much. So there's quite a few points that we can discuss, and I'm also waiting for any questions from the attendees as well, the participants. But two obvious points. Number one, if we go back, when you did the balloon interrogation, if you had seen compression of the coronary, what would you have done?
I would have stopped the procedure. I mean, the patient indication for the valve implantation was a bit borderline because the patient was developing increasing tricuspid regurgitation, but the right ventricular volume was not too big. The patient did not have arrhythmias and was symptomatic. So if I had seen a compression, I would have stopped the procedure and talked with a referring physician and discussed the case with everybody, because I couldn't see any point of proceeding with a coronary compression.
Okay, we'll come back to some of those points, but Ahmed, if you can, what would you have done if you'd been in the same position as Maria?
Question to me, Prof?
Yeah, yeah.
I would, Maria had a great case and a challenge that we always see with these kind of coronaries, but I would do the same thing. I will do the same process with sizing first, assess the coronaries. I do believe It is appear to be from the get-go is far away, but having the wire inside the coronary is a smart idea. But I think if it was a compression or a stretch or a change in the geometry of the coronary, I would have, to be honest with you, consider either smaller size valve in this case, if possible, maybe resizing and decrease the volume before really quitting out. Or if it
So
is
what
really
size? So what size?
the 28.
You've
Yeah,
only
I
got
mean,
two choices really
yeah,
on this
yeah,
valve.
yeah. But I mean, a 2 millimeter will make a difference, and I do believe that if there was a big stretch by sizing balloon, I would just decrease the inflation size and reassess again. And if it is really becomes a stretch rather than a compression or change, even with a smaller balloon, I would just bail out to go for a surgical intervention or other hybrid approach.
So Super in Thailand has got a similar case where it looked as if it might have been compressed with a bigger diameter valve. So they went the neck size down, like you mentioned, and there's been no compression. So that's one alternative. And then the other slightly easier one, Maria, is what would be the disadvantage of supraannular implant?
Yeah, as you can see here in this CT scan, for example, the place we had to be more careful was exactly the annulus. If we had gone for a supraannular implant, exactly this place can be distorted because the proximal crown is wider than this tubular size. So I didn't want to have the widest part of the valve in the most critical area. So even though the supraannular would have been feasible because the trunk was long enough and everything, I thought the safest place would be this position.
Yeah.
And it looks like the attendees always voted, although most of them voted for annular implant. Yeah.
Yeah. No, so those are very important points, and especially the risk of the proximal flare
Yeah.
impinging or pressing on the coronary. Any other points, Mark, or
Yes,
anybody else?
I do have another question. I do not remember exactly what the annulus or at the annular level, what your measurement was.
Yeah, it was between 27 and 30, depending on the lateral,
Okay.
right anterior oblique, and the size of the balloon was 27.8.
Good. Now, when looking at this slide, it looks like the central part of the venous is not completely open. In other words, probably a 28 would have done the job as well and decreased the low risk even lower. Would you agree?
Yeah, maybe. But anyway, when we saw the CT scan of the valve, I can't see any compression of the stent. So, and in the barrel position, you're right, maybe a 28 could have done the job. But when we did the barrel, the valve seemed completely round without any compression. Yeah. But you're right. Maybe it's like when you close an ASD with a 24 and you finish and say a 22 could have done. It's the same.
Yeah. So there's a comment in the chat box of a supraannular deployment of a shorter valve like my valve 30.5 or 32. If you could just briefly play the angiogram, Maria.
The right ventricular, yeah.
Original one, yes.
Yeah.
Because the problem, as I see it, well, let me ask, yeah. So keep playing that. Mark, what do you say to that comment or question about a shorter valve like my valve, 30.5 or 32 to be deployed? So balloon expandable.
I'm afraid that, I mean, the most restrictive part over here is what we can call the annulus. And the coronary typically will be in the annulus. And the pulmonary trunk, I'm afraid, is going to be probably very stretchable. So if you would put a valve in really supraannular position, I think it probably will not be very stable. And a 30.5, 30 millimeter probably is risky in a supraannular position, may put more pressure on the coronary artery than in this case a 28 or a 30 millimeter Venus.
Yeah.
So
a balloon expandable is going to exert more radial force than
yes. So both if you put it in the annular position and also supraannular. I mean, let's not forget, if you put something in a supraannular and you need some stretch in order to stabilize that valve, you're more likely, I think, to put stretch on that coronary artery, even if the stent is a few millimeters away from it. But I mean, you will have to pull and push on the pulmonary trunk. So I think it is safer to have, in this case, a mildly, either a correctly sized or a mildly undersized auto-expansive valve, because here also the retention, the stabilization of the valve will come from the flares. The distal flare obviously will inhibit the valve to go beyond the bifurcation, and also the distal flare was way too big to allow the valve to creep back into the ventricle. So I think in this case, this situation, this distance, the venous valve is probably far out the better option.
Okay, about one last point, which is very important, and Patrice has asked this question, and it's a good one. Do you always test the coronary arteries with the venous P valve in normal anatomy?
Yeah.
So Maria says yes. Francisco? Yeah.
Yes, always.
Yeah. Ahmed? You're muted.
What I will do is, if the CT scan shows the coronary with a good, visualization, if it is far away, I wouldn't. If it is a normal coronary anatomy, if it is similar to Maria's case, no, I would do a testing with it.
Yeah, but normal anatomy, Patrice is asking.
Yeah.
Mark?
I must say that I started doing the mental experience that based on the CT, without balloon interrogation, I make up my mind which valve to put in there. And I must say that with some experience, I mean, as you get older and more experience, that my tendency to change my mind after the balloon interrogation has decreased significantly. And I mean, I still do recommend the balloon interrogation because it's so in the protocol, but I think we're not far away from at the stage where probably in simple anatomy, based on the CT itself, if you have experience with the valve, that you could start doing it without balloon interrogation.
Okay. I'm not, I consider myself not very intelligent, and therefore I recommend with balloon interrogation selective coronary angiography, because all you need is one compression and severe problem, and that sorts you out. And I've seen what has been reported on the CT as normal anatomy having problems. So I still recommend, it adds 2 or 3 minutes to the procedure, and I would still recommend a selective coronary angiography. But thank you very much, Maria. That's been excellent discussion and a really good case. So Mark, let's move on.
Yes. So next speaker is Ahmed Al-Omrani, and we will looking forward to his case. Ahmed, the floor is yours.
Thank you very much. Thanks, everybody. I appreciate everybody's time and effort, and Eti trying to chase me to get this done in an appropriate time. I hope everybody will learn. This is an interesting case that I was invited to do outside of my center. A 42-year-old gentleman, an engineer in one of the oil company with a field expertise and a field job. He had a tetralogy of fellow as a neonate, which was repaired. In addition to additional muscular VSD, some of them has been patched and some were left. He's been progressively RV dilatation, worsening his RV function, PR, some of the MRI measurements. He's also exercise intolerance, and he's adamant not to have his chest reopened again for a surgery, considering his job and his future work. So we had assessed him. This is an image analysis, the pre-implantation that was sent to my dear colleague Fong, and he had some assessment initially. The coronary at that time was not really visualized well due to the protocol from that center was not prepared in the way that he wants, in addition to the anatomy. But one of the things that we noticed, and you look at, it's really a huge RVOT. There is some constriction at the what is appear to be the remaining of the pulmonary valve is about 27 to 32. He has a very long RVOT. So the thinking at that time whether it is feasible or not will give you some of the sort of like the schematic diagram with the valvular area, supravalvular, the ST junction with systole and diastole, and you understand how sort of like his RVOT distal before the bifurcation is so huge, and he has good for us that he has a very long RVOT. So the initial assessment there is, it became back and forth between us and the imager whether to be done or not, or to send him for sort of like a hybrid approach for surgery, and was giving as a red amber. I'll just show you some of his images from his echo. You can see that his RV is really struggling. Some of the VSD is also, his LV is getting affected. And from the short axis, you can tell that his RV is down. And this is how his RVOT look like from pre-assessment with the valve. You're looking at the echo here, you think there is really a good constriction here where we can have the valve placed. This is how his RVOT look by MRI. It is really a huge RVOT, and this is how his pulmonary leaflet, remaining of the leaflet in this case. So I will stop here. I will show you just his baseline angio, and I will leave it to play, and we'll hear from the team what do they think.
Yeah, keep playing that.
Okay.
So just to remind everybody, what are the measurements on the annulus here?
We'll just go back to, let me go back to the report. Here's are the measurements that we have. In the green line here is about 27.6, and when you go to the blue line here, a little bit more of the supraannular is about 3.8, 3.5, and here is in the RVOT is about 4 centimeter, and from the lateral projection is about 32 here.
And on the angiogram, did you do measurements? Or
we did. It's coming. Yeah, it's coming.
Okay. All right. So, any thoughts so far on this patient now, Francisco?
Okay, I see that the narrowest part of in this RVOT is the annulus again. Seems to be not that stretched than the Maria's case. And then the distal MPA opens a little more widely. So I think we will have to, again, to put the valve in the annulus, could oversize this more aggressive than we did in the Maria's case, and trying to get a better position of the distal valve into the distal MPA. Probably we will finish with a 34 millimeter valve, diameter valve. Okay. The shortest that you can.
Yeah. Sebastian.
Well, I think it's a quite challenging case with a big MPA, but still, as Francisco mentioned, I think there is a relatively rigid anchoring area. I think taking into account that the proximal flare is plus 10 millimeters, I think there is a chance to place a valve there. I would still aim at the largest size, so 36. Then the proximal flare would be 46. And if not, the annulus will hold to the tubular section, and then we still have the proximal flare that can keep the valve in the right place.
So you're looking at transannular implant over 36, and there's not much in it, whether you use 36 by 25 or 36 by 30, probably 25 would be better. Okay, carry on, Ahmed.
One comment.
Oh, Mark, yeah, sorry.
Yeah, I'm a little bit surprised by the discordance of the CT pictures which showed, what was it, 28 by 33 or something. And then the graph that showed at annual level that it was 30, 32, 36. Yeah, I mean, there is no line under 36, right?
Yes.
Isn't that discordant?
It was. That's why we thought there was the protocol of the CT and the images that were as acquired may not reflect what it was in the picture and what is actually plotted from this diagram. So at that time, to be honest with you, what I did, even I called the surgeon to be with us inside the cath lab in case that this case is not going to go, whether to go for a hybrid approach rather than just to go for a full surgical repair, to be honest with you.
Yeah. And do you... So, I mean, feasible is one thing. The length of the device, what was your reasoning there if you have to choose between a 25 and a 30?
Well, I thought 25 is more of if there is a, which actually retrospectively knowing that what happened to this, if it is going to go south, it would be a little bit of a shorter compared to the 30 lengthwise. So I thought having the 25 will be better for us, you know, just for my comfort zone, not to have it a little bit longer in case that it goes to, south.
Okay.
So you're relying really on almost the flares, whether it's distal or proximal, as the anchoring point.
Absolutely right. You're like with us, like being with us in this case. So basically, one of the things that I want to also to see your comments also in this case, it may, if you look at our wire position and we chose the LPA, we actually spend more half an hour to get the wire and the system to the RPA. We could not really. Once you have everything there, it just get flipped and go to the LPA. So finally, we just said we're going to proceed with the LPA position. So I thought just to keep that in mind in future discussion when we see what happened and what is the outcome of this case, you may think differently.
One quick question, Ahmed, is from Patrice. Do you think rapid pacing is useful to stabilize the balloon when you're doing balloon interrogation?
I agree. That was another point that was thinking is like one of the things that I put in one slide is, you know, rapid pacing, having maybe a different balloon, sizing balloon rather than this one. This one is the ASD sizing balloon, which is the 34 by Amplats. Maybe having the new mid sizing balloon with a larger balloon diameter, it may have, and a longer one, it may have actually a better stability compared to this one that we use.
Yeah, so if you use a 40 millimeter PTSX with 5 centimeter length.
Yes.
Probably. Carry on, Ahmed.
Having sheath in RV would also help to stabilize the balloon.
That's what we. You're right. That one of the things that we had is if this sheath was already in place with the sizing similar what I did here, is to have the whole system stable when we release the first part of it or 1/3 of it. So this is basically.
Sorry, Ahmed. Just going back on a technical point, if you have a dry seal sheath in place, the ASD sizing balloon, the Amplatzer, is too short.
True, you're right.
So you'd have to definitely go for PTSX.
PTSX, yes. That's what one of the technical things that we had in our discussion at the cath table. So this is basically we try to, you know, you look at it, it's sort of like a more of a straightforward, you know, you look at the release, you know, the dots is in position, you see the proximal or the RVOT side where we are trying to plan across the pulmonary valve annulus, quick sort of like an injections that we have to document our position and see what we are doing. It's looked like, you know, in a stable way, and we are now opening the valve completely and releasing it. You see more of a stable position here, looking good. And the valve did a little bit move. If you look at it at the, you know, initially before expanding all the thing here, just look at it and compare it to the superior suture line on the chest, and you see the valve is did a little bit go down south a little bit, but we felt that it's looked good. And when we look at it from different injection before pulling the carrots over the valve, and where is this valve leaflet sitting with the annular level? Any other questions before we proceed with the next slide?
Yes, I would say this looks nice. If you look in the lateral, it looks to me that the inferior part where the annulus is, So the posterior side is being squeezed by the muscle. I mean, it moves.
Yeah.
So that means there will be retention at that point. And also your flare is nice in the trunk. This looks as good as it could get, I think.
Okay.
My question or comment really is there a shortage of contrast where you were working?
Well, we'll defer that, Jack.
Okay.
No, I agree with you. You're right. You're right. So
I have one comment just before you release the system. So if I have such a big anatomy and I'm afraid that it will dislodge, I take a few more minutes because I believe, maybe this is wrong, that there is still this temperature of blood can make the nitinol stiffer, bigger. So did you remove the delivery system immediately, or did you wait?
well, no, I did not wait, to be honest with you. Because I was worried about, as I mentioned, is the issue that when we started moving it, if you notice that when I was alluding to the superior suture mark and the tip of the system did a little bit go down, so I didn't want to really risk of having things, moving and having that cardiac output without stability. So I felt better to release, similar to what you see now. It's look favorable. I thought that it was look good. And
I agree with Sebastian. I think that's a very important point.
Cool.
I tend to, even with half exposed, wait for the nitinol to warm up so that it's maximally expanded before I go for the rest of the release.
So this is now after we release. This is we notice it by fluoro that it's a little bit went down south. You see where's our superior margin compared to the first. We are now reaching to the second suture line here. This is the takeoff of the RPA here, and from the lateral projection. Sorry. And from the lateral here, you will see that it's actually almost at the this annular level is only at the level of the superior part of the distal flare or the MPA flare. So now the valve released, it is in position, it is functioning. We did this echo, and this is how the echo at the cath side look like. Should we get out of the cath lab, leave it?
So it's quite a way down, isn't it?
Yeah.
Mid RV.
Yeah.
Okay. Francisco.
I think it's a challenging case. I understood that it was really difficult to get position in the RPA, but
True.
These are the cases that I think it worth to spend all the time you could to get position in the right pulmonary artery, because the alignment would be better when you go from the pulmonary arteries. The valve will move a little higher even, and not proximal. So far looks, I guess, stable enough to leave the cath lab. There's no more that we can do right now, and wait for the morning after echo.
Okay, we'll come to that. Sebastian.
And was there an increase in tricuspid regurgitation?
No.
No. And what about ECG on this echo? I don't.
You see that it's actually stabilized. He doesn't have any PVCs now.
Do you recommend beta blockers, for example, to avoid arrhythmias, because there is a risk of arrhythmia due to this contact between the device and the ventricle?
That's actually maybe the next day or two. This is now I'm in the cath lab.
Yeah,
I have this echo in the cath lab.
Yeah.
We've got to make a decision. Maria.
Yeah.
You're muted again.
Yeah, we had a similar case in which the valve was left like too deep into the right ventricle with normal function and everything. The patient was having extra beats and arrhythmias, and he had a symptomatic arrhythmia 3 days later. So in these cases in which we have a valve that is being compressed by the infundibulum and maybe too deep into the right ventricle valve, I'm very careful, and sometimes I leave the patients more days in the hospital, because it's terrible if they have a an event at home just a few days. So in these cases, I'm very, very careful, and I watch also the tricuspid valve.
Okay, important points there. Mark?
Yeah, annoying. What annoys me, can we see the previous echo? There's a lot of space. I mean, it's hard to see the annulus if you look at the short axis. Yeah, over there.
You mean the baseline or the post?
No, that one. Yeah. So it looks like, as you said, that the distal flare is now at the annulus position. Yeah. At that point, there's not too much you can do and see whether the patient tolerates this position of the valve and whether it's going to be arrhythmogenic. If as the valve is functioning right now, so that means also that the ventricle will shrink, and that it may not be arrhythmogenic right now, but it may be arrhythmogenic in 2 or 3 days as the ventricle will decrease in size. So it's something that you need to watch.
And just to get out of the way, there's a comment about push the valve up with a sizing balloon. Right. So I'm just going to pick on Sebastian.
I wouldn't do that. I did see one case where the valve was positioned slightly lower towards the right ventricle, and operators tried to do that, and that wasn't effective. I don't think this would be effective, and it could cause harm to the valve, also to tricuspid valve.
Yeah. So that's one of the concerns. And quite a while ago, we had one case, and we talked to the surgeons, and the surgeon, because we were talking about replacing the valve, and he said, "Oh, the valve's it's a good size." And so he said, without going on bypass, I'll just pull up from distal flare and suture the valve in place. And so that's what we did. And the valve is still 8 or 9 years later, still functioning. So, there are rather than sit around and wait for arrhythmias and other complications, tricuspid valve issues to arise, that would certainly be a reasonable option. Ahmed, carry on.
So what we did, we actually, as Maria mentioned, we kept him for a couple of days. It's actually 1 week. He stays the same. He was doing well. He's mobilizing. He started to be boring from the hospital. And this is the valve we're doing like serial. This is his valve. Let me just go back. This is the discharge. This is the discharge echo. This is how his valve looked like. He has rare PVCs, not too much. He was like having maybe 1 to 2% by the telemetry that he was in. So we kept him on beta blocker, bisoprolol, which basically he tolerated very well. And he came after 5 months almost. This is how his valve looked like. How does his echo look like? He's back working in the field. And you see this is scary also, as you mentioned, that part is inside his RV, but nothing affecting his tricuspid valve or other structures. And the valve continued to function well.
Okay, interesting one. I must say I would have had a low threshold for surgery, but looks as if it's staying well. Again, there's another patient who 6 or 7 years later, I don't know if Warwickon has joined or not, but 6 or 7 years later, they had to explant the valve because it carried on causing increasing tricuspid regurgitation because it had gone a bit low. So that's something that has to be kept an eye on. But very interesting. Any other comments from anybody else? And otherwise we'll move.
What was the surgical risk of this patient? Is at high risk for surgery or not?
No, the patient preferred that this valve to be done by cath, and he agreed that if it fails from the cath on the same setting on the table with the GA, to proceed for the hybrid approach.
So for me, the only problem in this situation is that if you want to remove surgically this Venous P valve later, it will become quite difficult because of the endothelialization of the device and the ventricle. So that is the limitation. That's the reason why I would like to know the surgical risk of this patient.
So just to answer a little bit of that, the valve that was I mentioned from Bangkok that was removed 6 or 7 years later, the surgeons did not have any problems. They managed to really easily remove the valve. So that's based on just one patient. There's a question from did his right ventricular size and function improve? Ahmed, probably not been done.
Well, not yet. I mean, this is just this is how his RV look like and the LV. But he felt very well when he came in at the 6 months follow-up. I mean, 5 he's questioning about whether using the beta blocker. We requested the Holter. Unfortunately, I don't have an access to that yet. He's from outside the institute, so we're getting the Holter and a repeat MRI and the CT also, similar to what Dr. Maria did. Beautifully showed the frame and all of that. So we're planning to do that in the future.
Okay.
Thank you.
Thank you very much. That was excellent. So,
I think we have to proceed. Thank you so much. Next speaker is Patrice Guérin from France. I mean, he has a vast experience with TAVIs, and we all know that in TAVIs, quite a few things can happen with HALT. And he's going to teach us and tell us what lessons he learned from his TAVI experience and how much we can extrapolate that to the pulmonary position. Patrice, the floor is yours.
Thank you, Mark. I would like to share my screen, but it looks difficult. Or you have the presentation of the YAT.
We see you.
Adam, have you got his presentation?
I believe I have the presentation.
Okay, I get it.
Oh,
it's okay. Well, so thank you very much for the invitation. And I would like to speak with you to share my experience with the valve thrombosis after TAVI valve implantation and the relation between this issue and the problem of potentially thrombosis of the venous P valve. So here's my first question. You can take this picture if you want, because the question will be quite difficult, of course. Sorry, I go too quick. So based on the literature, on transcatheter valve implantation, TAVI, concerning subclinical valve thrombosis or ALT, with or without reduced leaflet mobility, what antithrombotic treatment do you envision for your transcatheter pulmonary valve? Do you choose the dual antiplatelet therapy, the new oral anticoagulation with or without aspirin, or aspirin alone? So the answer to my point of view, according to what we have in the literature, is aspirin alone. And we, according to the bibliography after TAVI valve implantation. But we recently published this paper that I'm sure you read previously, but we made a systematic CT scan for our first 9 patients implanted with the venous P valve. And we were surprised, not really surprised, but we found 7 patients with ALT thrombosis. I mean that there were no dysfunction of the valve, no restriction, no regurgitation. The mean gradient was 8 millimeters. So the function of the valve was really perfect. But when we did the CT scan, we found, when we did the CT scan, we found only 1 patient without anything, and it was the only patient with only aspirin. There were no reduction of leaflet motion in this population. So what do we know about TAVI and ALT and clinical and subclinical thrombosis? We know that hypoattenuated leaflet thickening or HALF and reduced leaflet motion have been identified early in the field of TAVI. And we know that subclinical leaflet thrombosis can be detected by CT scan. It is the ALT, and it can be associated or not with a reduction of leaflet motion. And it could increase the gradient, that is a very important point. and it could lead to adverse clinical effect like TIA or stroke. So ALT can occur with or without a reduction of leaflet motion. So we know that clinical thrombosis could be observed after TAVI valve implantation in 1 to 4 or 5% of cases. Reduction leaflet motion in 10 to 15% after TAVI, and subclinical leaflet thrombosis, depending of studies, we can imagine something between 20 and 40% of cases. So the reasons are quite unclear nowadays, but probably that the injury of the pericardial leaflet could be responsible in part of this phenomenon. The incomplete asymmetric over or under expansion of the TAVI valve could be responsible of a modification of the hemodynamic of the valve, and a quite hemodynamic reason like misalignment of the valve in the outflow tract. So I would like to share with you 4 studies. The first is a registry. It is a reserve registry. The objective of the reserve registry was to report the prevalence of subclinical leaflet thrombosis in surgical and transcatheter aortic valves, and the effect, the potential effect of new oral anticoagulant. They found 100 cases out of 900 cases with subclinical leaflet thrombosis, including 5 patients with surgical valve and 100 patients with transcatheter valve. That means that the risk of thrombosis with transcatheter valve is quite higher than after surgical valve, but thrombosis of surgical valve does exist. The median time from aortic replacement to CT was 80 days. ALT was less frequent among patients receiving anticoagulation, and especially patients suffering of atrial fibrillation, than among those receiving dual antiplatelet therapy. And new oral anticoagulant were quite equally effective as warfarin, and subclinical leaflet thrombosis were resolved in all cases after anticoagulant and not resolved without anticoagulant. I mean, antiplatelet therapy is not enough to treat this patient, and this is a problem. So a greater proportion of patients with ALT had a high gradient after valve implantation before leaving and going home. We found more than 20 millimeters of mercury. It is a sign, an echocardiographic sign of valve thrombosis. Or it's possible to find an increase of the mean gradient of more than 10 millimeters of mercury. And we know that ALT is sometimes associated with embolism like TIA or stroke, whatever the reduction leaflet motion was present or not. So the take-home message of this registry is that it's occurs frequently in bioprosthetic valve, and especially after percutaneous valve implantation. And anticoagulation, but not dual antiplatelet therapy, was effective to prevent subclinical leaflet thrombosis. And it is associated with a risk of TIA. It's not so simple because there is a risk of TIA or stroke. The second study that I would like to share with you is a popular TAVI study. In this study, patients had indication for anticoagulant, and they were randomized between anticoagulant alone or anticoagulant plus clopidogrel for 3 months. And the result of this study is that if you associate anticoagulant plus clopidogrel, you will have more complication, more bleeding complication, without really any advantage in terms of ischemic complications. So the idea to treat patients after TAVI valve implantation with anticoagulant plus clopidogrel or aspirin, in fact, is always a bad idea to protect the valve of ALT and with or without reduction leaflet motion. The second study that I would like to share with you is the Galileo one. In the Galileo study, the primary effect was a composite one of death and thromboembolic events. And in the Galileo study, the goal was to compare the rivaroxaban, an oral anticoagulant, to an antiplatelet therapy. There were, in the Galileo, there were indication for anticoagulation. And they were randomized between antiplatelet and rivaroxaban. And the result of this study is that rivaroxaban was responsible for a high risk of death and thromboembolism complication and bleeding. So finally, the Galileo was early stopped because the risk with the rivaroxaban was too high compared to the benefits. So it is a bad idea to treat patients with rivaroxaban if there's no indication for anticoagulant. But you have to take into account the Galileo sub-study with CT scan evaluation after treatment. And in this study, it has been proved that you can limit the risk of ALT, and so the risk of valve thrombosis, symptomatic or not, and the risk of reduction leaflet motion. So it could be interesting to use anticoagulant to limit the risk of thrombosis, but the risk of the anticoagulant in itself is responsible so severe complications that it's not a good idea to treat with that if there's no indication for anticoagulant. So you can see the effect on the reduced leaflet motion and the effect on the leaflet thickening, that means on the ALT phenomenon. The last study that I want to share with you is the Atlantis study. In this study, they compare the apixaban to the VKA if there were an indication for VKA, or the apixaban if with the antiplatelet therapy, a single antiplatelet therapy, if there were no indication for anticoagulation. And they proved that there were the efficiency of apixaban was the same of VKA to protect the patient. And they proved that there were no advantage to apixaban compared to antiplatelet therapy if there were no indication for the apixaban therapy. And in the sub-analysis with the CT scans, they proved that there were an advantage to limit the risk of ALT, of reduced leaflet motion. So the key message is that in the population of TAVI, what do we know? We know that it's quite classical to have a thrombosis of the valve. It is possible. It's not a drama. There is no indication for anticoagulation. In popular TAVI, popular TAVI proves that aspirin alone was safer than aspirin plus clopidogrel. After valve implantation, there's no indication for dual antiplatelet therapy. Thanks to the Galileo study, we know that rivaroxaban strategy increased mortality and bleeding. And thanks to the Atlantis study, we know that apixaban show no clinical benefit compared to antiplatelet therapy, single antiplatelet therapy. If there is an indication for anticoagulant, thanks to the popular TAVI, we know that anticoagulant alone is safer than anticoagulant plus clopidogrel. Thanks to Atlantis, apixaban is non-inferior to VKA. And so anticoagulant alone is the best strategy for this patient and without adding any antiplatelet therapy. So what about transpulmonary valve replacement? We know that the same bioprothesis implanted in the right side valvulopathy have shown a higher risk of ALT. Maybe it is due to some hemodynamic condition in the right heart, but nevertheless, it had been observed up to 60% of ALT in this study, and 17% of patients suffering of reduction leaflet motion. So here's an overview of the cases and the disease and the reason why these patients were implanted. And this is an overview of the therapies that will take in place after the percutaneous valve implantation. And you can see that we are far away from the recommendation of the TAVI valve. Here is another study. I will go quickly now. Is the flow chart of the population. They define the harm as a sort of little reduction of the leaflet motion. And here's an overview of the bioprosthesis implanted. And you can see that usually it was a balloon expandable one, probably, I think, a Melody valve and in some cases, Sapien valve were implanted. And that is a very important point. You can see that dual antiplatelet therapy was used in more than half of the population. And you can see that in 1/4 of the population, it was oral anticoagulation plus aspirin. Here is an overview of the therapy, so I go quickly now. But what do we know from this study? It has been proved that the ALP prevalence was close to 70% and the HAM prevalence of 6%. This is a very important point. Valve deterioration in all cohort was close to 7%. But in case of valve deterioration in ALT, the valve deterioration was close to 37% if ALT was present. So that is a very important point because ALT could be responsible for valve deterioration. Here's a view of some of the CT scan, by example. And that is an important point too. In case of ALT, the delta mean gradient between the postoperative gradient and the gradient during the visit, the control, you can see that the gradient will increase. And usually this increase of the gradient could traduce the presence of a valve thrombosis. And you can find that because we implanted recently the first evoke in tricuspid position in a tetralogy fallow. In the tetralogy of fallow, we know that the risk is present too in case of tricuspid valve after tricuspid valve implantation. So maybe because it is quite a big valve, a big prosthesis, so the problem is quite large. We just have to deal with this problem and to find the best solution and the best therapy. You can see that in this population, in case of tricuspid valve implantation, it's possible to treat the valve thrombosis by using oral anticoagulation. Thank you very much for your attention.
All right. Thank you very much, Patrice. A lot of things to think about. Any questions from anybody whilst they're thinking? Patrice, the big problem is in our population, we're talking about younger group of patients, whereas the TAVI are at the other end. And so that's number one. Number two, we've got pressure differences that we're dealing with for the systemic side compared with pulmonary side. So there are so many different factors that make it difficult for us to come up with a clear recommendation, aren't there? So, and then the number of patients is small. And so it's not as if we can say, oh, let's do a randomized multi-center trial. So is there anything you can guide us with on, you've made a few sort of recommendations, but anything you can guide us with when it comes to assessing and managing HALT?
To my point of view, it's difficult to do a parallel, of course, between TAVI valve and pulmonary valve replacement. Nevertheless, we learn a lot thanks to the TAVI valve implantation. I think that the biggest the valve is, the higher the risk of HALT thrombosis will be present. I'm not quite sure about that, but we can imagine something like that. So it's not a drama to find a HALT on the Venus P valve because it is a big valve. A large diameter. So I just want to deal with that and to find the best solution to prevent the thrombosis and the early deteriorations of the valve. To my point of view, and that's what we do now in my center in Nantes and is the Hôpital Européen Georges Pompidou in Paris, we decided to treat our patient with aspirin alone for 3 months. And after 3 months to do a systematic CT scan. And in case of HALT, we introduce an oral anticoagulation. Because it's true that we are in the right position, so it's easier to introduce an anticoagulant because the risk of bleeding will be present, but we can accept the risk of thrombosis because the risk of embolism from the right side of the heart is not so severe and dangerous that the risk of embolism from the left side of the heart. So for us, it is aspirin alone, CT scan at 3 months, and oral anticoagulation depending on what you see on the CT scan.
Okay. So very briefly, Mark, any comments about this?
Not specifically. Patrice, what do you now give to your pulmonary valve implantation patients?
What do you know?
Which drug, what regime of
usually
do you give?
Due to this study, apixaban is the only new oral anticoagulation that we use. It is always apixaban. No warfarin, no VKA, I mean just apixaban.
Okay, and with that you're pleased. So that means no bleedings in your patient population, and also a very limited of halts or other problems. Is that correct?
Yeah, it's true.
Okay, Maria?
Yeah, thank you very much for this very interesting talk. And I would like to ask you, when should you recommend to perform the first CT scan in the follow-up of a patient who has undergone a transcatheter pulmonary valve replacement? And would you have to repeat it if the first CT scan is normal? How many CT scans do we have to do? Because to me, it's like we need a better way to monitor the valve function. But I would like to know what do you think about this?
It's a very good question and a very difficult question to answer because we decided, without any proof, to do the systematic CT scan 3 months later after valve implantation. And we will introduce, in case of HALT, we will introduce the oral anticoagulation, of course, but what will we do after that? Probably we will make another CT scan 6 months later, but you're right, a CT scan plus another CT scan, but we have to deal with the fact that there is potentially a relationship between early deterioration of the valve and thrombosis of the valve. So we have to find the good way to find the good way between the risk of deterioration and the risk of the CT scan and the thrombosis. So I do not know more than
so very simple, very simple and brief question and a brief answer, I hope. If you rely purely on echocardiogram and show that there is a change in Doppler velocity across the valve, that should then prompt you to do a CT scan. Is that a reasonable approach?
Yeah, I think it's a good idea.
Yeah. Okay. All right. So I think that's a fascinating talk. There's another quick question, and then we'll move. The question is from does the degree of HALT affect the decision to give anticoagulants, taking into consideration that the PPVI population is young? I think that's a difficult one, isn't it, Patrice?
It is a difficult question, of course. Yes, I think that you can't avoid a little HALT on this type of prosthesis because it is a quite large one. But probably I will not introduce oral anticoagulant for a very small HALT. But we have to define that. We have to work all together and to define a good strategy and a recommendation for this population. Probably we have to imagine something, a flow chart for this patient, decision making, and we have to imagine something altogether because I think that there's nothing very precise. The D-dimer, I do not have any idea about that, even if it's true that it is a good question.
Okay, Patrice, last question is, and we'll move on after that. What would be the interest of D-dimers monitoring in this HALT situation?
Yeah, I saw that, but I can't answer to that because I didn't have any data.
I don't have an answer. Okay, thank you very much, Patrice.
Thank you.
Move on, Mark.
Thank you.
You'll have to unshare, Patrice.
Because time is going on. First, Francisco Gary from Chile is going to tell us about the experience up to 9 years nowadays with the Venus valve. Francisco, your turn.
Okay, thank you. I'm coming. Okay, thank you to the Venus team for the opportunity to participate in this. I will share our experience after 10 years being using Venus P here in Latin America. That was my disclosure. Back in 2015, we did the first case of Venus P here in Chile. And after that, we have been doing implants in most of them in Argentina, some of them in Brazil, Colombia, and lately in Mexico and Uruguay. When we stopped this for a review last year, we have been done 136 implants in these last 10 years with a success procedural rate of 100%. That speaks really well of the patient selection, I should think, but also speaks well of about the procedure, really safe, very reproducible. So we are very happy with this experience. The mortality has not been a problem for the procedure or during the follow-up. Reoperations, we have had 2 cases of patients who need reoperation, surgical operation. One of them was a patient with a, very similar to the case of Dr. Ahmed, was a patient with a severe tricuspid regurgitation because of a proximal malposition of the valve at the beginning of our experience. And this patient underwent a surgical tricuspid replacement 2 years after. But at that moment, the Venus P valve was explored, looks good. The functioning of the Venus P valve was good, so it was kept in position. Was not necessary to explant the Venus P. And the other patient who underwent surgery was a patient with a paravalvular leak, a significant one, and so this patient underwent a surgical. The surgeon did a plicature over the Venus P valve. So it was not necessary to remove or explant the Venus P valve. So end of the story, we have had no explantations in this experience after 10 years in more than 100 patients. What about endocarditis? If you would ask me that last year, I would have said that no cases of endocarditis. However, last year, we had the first 2 cases of endocarditis related to Venus P. One was a patient who presented the endocarditis 2 months after the implant, and it was related to an implant of a subcutaneous anti-pregnant implant under the skin, okay? And the other patient presented 2 years after the implant. It was related to a urinary tract infection. Both cases were medically treated. Was not necessary to explant. Was not necessary to do a valve in valve. The valve has been working good with no more than a mild regurgitation. So again, no need for reintervention or no need for explantation so far in this experience. What about arrhythmias, ventricular arrhythmias? We have 2 cases. One case with a ventricular tachycardia who surprisingly presented 18 days after the implant. This lady needed electrical cardioversion, and the EP team put her on antiarrhythmic therapy. And they did the study, the proper study, and finally, after 6 months, they stopped the antiarrhythmic therapy for this lady, and she has had no problems since then. And the other patient was a patient of mine who presented with very frequent PVCs immediately after the implant. So we start with a beta block therapy, and we keep this kid in
as an inpatient with a monitoring. And after 2 days, when the PVCs were decreasing in amount, we discharged him home, and his primary cardiologist stopped the therapy 2 months after the implant, and he has been doing well. So far, the ventricular arrhythmia problem has been very unusual, and it seems to be self-limited so far. What about the sizes of the valve that we have implanted? You can see here in the distribution, most of the valves has been between 30, 32, or 34 millimeters. So you can have an idea of how large are the RVUTs that we are dealing with. And what about the length of the valve? This is interesting. At the beginning of our experience, most of the valves that we implant were 30 millimeters length. And then we moved in the middle part of our experience, we moved to choose shorter valves, and most of the valves that we implant here were the shorter 25 millimeters length. And even more interesting, in the last part of the experience, we have been implanting almost exclusively 25 millimeters length valve, the shortest available that we have. But we have even 2 cases with a very short MPA that we have implants 20 millimeters length valve that the company made to us upon our request for this particular 2 patients. So I think that we are moving to a shorter valves, and I think that is the thought of many people. Other thing we learned, at the beginning, we followed the company advice that park the wire in the distal LPA, but you can see very similar to the case of Dr. Ahmed present, the alignment of the delivery system is not well aligned to the axis of the MPA. And that could expose you to a potential risk of a proximal malposition, as we saw. It's possible to do from the LPA, of course, but now every time we could choose, we prefer to park the wire in the distal RPA, in the right pulmonary artery. I think the alignment of the delivery system with the MPA is better, and you can see that when you open the valve or you move from the RPA into the distal MPA, the valve will not follow down into the south, as Ahmed said. Actually, the valve could move a little higher, so it's a safer position. So every time we could choose, we prefer now coming from the right pulmonary artery. Other thing we learned was, in this particular case, when we have a malposition of the valve, you see that this particular valve on your left fell down into the proximal MPA, partially deployed, and it was possible to retrieve. We learned how to do that by pulling back the partially deployed valve inside of the long sheath. So as a safety option, we always try to use a long sheath like a Tri-Seal or a long sheath from Venus that we have available here in Latin America. They call Axis. So we use the long sheath just to be as a safe option to retrieve the valve if we need. And you can see that here on your right, that it's possible to recapture the valve inside of the capsule, remove out of the body, clean it, review the valve. And in these 2 cases, we implant the same valve again. And for this case that you have on your left, we change the PA branch and everything goes smoothly for that. What about the fracture? We saw fractures at the beginning. We were very concerned about that because we saw that very early as 6 months, fractures in the proximal end of the valve appears. But however, in the follow-up, we have images, like in this case, same patient, 2 months after, 30 months after, 9 years after, the fractures are not progressive in time. And most important of that, they have no fracture, no functional involvement. The shape, the cross shape of the stent remains quite good. And the most important, in the same patient, that the functional of the valve is perfect, no matter the fracture. So I'm not concerned anymore about the fractures. I look for that just if we saw a deterioration in the function of the valve. I think it's part of the behavior of the stent in this valve concept. Okay, the other thing that we looked at the beginning, it was for the ideal candidate, you know, the tubular MPA with symmetrical PA branches, but you know, the real life, there's a lot of options for MPA configurations. So soon after we begin our experience, it was very successful one. We begin to deal with patients more challenging and very fast. I will show you some examples of these patients, by instance, that we implant Venus P with asymmetrical PA branches, or this patient with a pyramidal shape MPA, Venus P was possible to implant without the problem, fixing the problem for the patient. This particular patient who has a very dilated distal MPA and aneurysmatical branches because of a pulmonary valve agenesia, and Venus P was possible to implant, of course, at the annular position and fix the problem for the patient. It's working okay. This patient with an hourglass shape configuration of the MPA and Venus P was possible to implant without a significant problem at all, and it's working. Or implants with a patient who had tented in the proximal PA branches. We analyze case by case, but it's possible to do as well. We have done a couple of cases. This patient who has a single PA branch and we implant Venus P without a problem, that results in a very significant clinical improvement for this particular patient. This lady is very happy with this Venus valve for her. And this is a very unusual case with a 1.5 ventricle physiology, with a severe regurgitation of the pulmonic valve. Surgeons who didn't like to operate this, so it was possible to, even coming from the left PA, that is not our best option. We could implant the Venus P there in a very nice position there on your right, and you see recover total function of the pulmonic valve competence, you know? And even this patient, who was a patient with a very severe dilated MPA, larger than 36 millimeter at the basal measurements. So for this patient, we convinced the surgeon who helped us in a hybrid procedure. The surgeon did MPA plicature, and we proceed through a perventricular approach to implant a Venus P inside of this plicated MPA. You see some images of the procedure, and the result was really good. For the first patient, we include MRI evaluation. And here you have 10 patients who has an MRI performed 15 months after the procedure. You have a nice image of how the Venus P valve looks in MRI, and you can see, of course, if the valve is functional, it will produce a significant regression or improvement in the RV volumes. What about the durability? I distribute a poll into the operators who have patients with a more than 5 years follow-up after the implant. And for those 47 patients or 47 polls that I received back with a follow-up mean of 7 years, we have had no explantations again, no mortality during the follow-up, no significant regurgitation or stenosis has been reported. And because of this, we have had no need for re-interventions, no need for valve-in-valve procedures so far. Of course, we are waiting for that, but so far, 7 years in a mean of follow-up, no cases for that. This is a picture of the first patient, Luciano. He's now a 22 years old engineer student. And these are images of his valve last year. And you can see the valve has no more than a mild regurgitation, where with a peak gradient on echo, no more than 50 millimeter mercury with a mean gradient of 6. And if you can see in the higher image with a 4-chamber view, the right ventricle enlargement is not a problem anymore. Looks a little small even. So finally, after 10 years using Venus P in our patients here in Latin America and several countries, we have had no long-term valve-related mortality or morbidity. It seems to us that it's a very reliable valve. The procedure is very reproducible, safe, and could be used in different anatomical configurations. The long-term durability so far is really encouraging in terms of competence and stenosis, endocarditis, and rhythm disturbances. Of course, they are significant concerns to us, but so far they have been anecdotal to us. And no explantations, no reintervention so far, and no valve-in-valve procedure we have needed yet for these patients. So thank you for your attention. That's it.
Thank you very much, Francisco. One little question. What is the regime of anticoagulation or anti-aggregation that you recommend in South America?
We are still stick to just aspirin alone.
Yeah. So that also still works.
We're waiting for more information about that, the health problem, but so far we are using just aspirin.
I think your data were very, very promising, and I'm afraid I have to cut everything short because we're passing our time now. And I will ask Sebastian from Gornecki from Poland to proceed and tell us when very large housing diameters do matter. Sebastian, all yours.
Mark, thank you very much for introduction. Can you confirm that you see my screen?
We do.
My slides, okay. So once again, thank you very much for having me here and for giving me a chance to present. As we could learn from Francisco a few minutes ago, this valve, particularly this one, shows very long and good outcomes in the long term. But we have other devices available to treat dysfunctional outflow tracts. And we know that they can fit into various anatomies, but eventually they will fail. And the question remains, what do we do when these patients come back to us? Historically, I believe we had, one option was to send them back for surgery, and that was done for many years with the balloon expandable valves. Later, some centers started doing valve-in-valve implantation for balloon expandable valves. But in the self-expanding platforms, there is a limited experience with valve-in-valve implantations. So let me start with a question to you all. If you had a patient that initially underwent successful largest Venus P valve implantation, but several years later comes back to you and needs reintervention, what do you do? Do you take this case on, or do you send the patient for surgery? Or maybe you want to implant a valve, maybe balloon expandable or self-expanding valve, or perhaps you have idea to do something else. Please share your thoughts on that. I cannot see outcomes. So Adam, could you share with me results?
The result so far is 73%, 75% says implant a self-expanding valve, 17 says implant a balloon expandable valve, and 8% sent for surgery. Okay, and any other ideas? So far, there's 0%. Now, I think
okay, so majority would intervene in cath lab, and majority would go for a self-expanding valve. Well, that's interesting, and I like that concept. But when we look at available self-expanding platforms and large outflow tracts, we have two ways of treating patients. So one is that we can implant a device that reduces outflow tract. And we can do it in a single step, as with, for example, Harmony. or we can do it with a two-step procedure with Altera and then Edward Sapien. Or we can also implant something like Venusp, a device that is supposed to fit into the particular patient's anatomy. And depending on the initial valve and the initial implant, we then have to have different strategies for valve-in-valve implantation. So let's go through three scenarios. Valve number 1 is 25 Harmony, 29 Altera and Sapien, and 36 Venusp. We should expect some remodeling around these valves and those RVOT reducers. Obviously, they will not fill in entire outflow tract, and there will be gaps that will have to undergo rebuilding, and that might get rigid or not, but something needs to happen around the valve. If the patient with Harmony comes back to cath lab, well, there are several papers, both on bench test and in patients showing valve-in-valve with balloon expandable valves. But what is very important is that these cases require several balloon dilatation to stretch the frame. And as in this case, you can see there were at least 3 balloons used with high pressure to test distensibility. And at the same time, aortic root angiography was performed to make sure that there was no aortic compression or coronary compression. So this looks similar to what we used to do, and we still do for right ventricle to pulmonary artery grafts that are calcified, and we need to stretch them to place a valve in. In the initial Harmony TPV clinical study, out of 86 implants, 6 required valve-in-valve, and 3 patients received Melody, 3 Sapien. So obviously, it is feasible to perform valve-in-valve in Harmony. In this case series, you can find a lot more about location of narrowings and about mechanisms and about challenges of treatment, because some of these narrowings are quite rigid and require multiple balloon inflations, but still with a proper approach and stenting or direct sapien valve implantation, valve-in-valve is possible. If we look at the Altera with Sapien Inside group in US, they did bench tests and animal experiment. They placed multiple self sapien valves, but in this case, they used two-step procedure, two-step technique. So first was overexpansion with 2 balloons, 18 and 20 millimeter Atlas at 14 atmospheres. And then in the next step, they used a true balloon to circularize the valve complex. Initially, with one sapien valve, the inner diameter was 27, and with 2 valves, it was around 26. Eventually, they were able to put 4 valves in, but keep in mind that the inner diameter wasn't close to 29. And in this paper, you can see actually experience of 2 patients that underwent valve-in-valve, and one of them had Altera and Sapien. And in this case, a similar approach was performed, ovalization, but with 2 similar balloons dilated to 20 atmospheres, and then circularization with a single large diameter balloon. If you look at Venusp, the largest size, so what are our options? We decided we're going to go to cath lab and treat this patient. And this is what happened in Ireland. And these are images thanks to Damien Kenny. He had a 20-year-old patient who underwent 6 or 7 years earlier successful Venusp implantation, 36 millimeter, 25 length. However, several years later, due to progression of lymphedema, that patient had moderate PI, but the decision was to implant another valve to try to reduce pressure in the right ventricle, right atrium, and to improve symptoms of lymphedema. So we have 36 millimeter valve, and please help me or share your thoughts on reintervention in this particular case. So the valve was 36. the measured tubular portion was 34.1. So what would you do? Would you implant same diameter and length valve, so 36 by 25, or perhaps you would go for the same diameter but maybe longer? Or would you go for a smaller diameter, like 34, with the same length, or maybe smaller and longer? Adam, could you one more time share results with me?
Yes. So far, 50%, 53% says 36.25. You have 40% that says 34, and 7% says 34.30.
Okay, so majority would go for the same length. Some would use the same size, 36, and others would use 34. Well, so actually what Damon did, he used the same size, exactly the same diameter and length. And as according to his testimony, it was easy to introduce the valve and deploy the valve. There was some not complete alignment of the tubular section, so he used a big balloon to try to adjust it. But overall, the outcome was really good with some trivial central regurgitation. What we decided to do actually is based also on this experience that was that report that comes from China. Actually, this isn't largest Venus P valve, because initially this was 26. But this 26 millimeter valve lasted for around 5 years and then needed reintervention and was treated with 28 millimeter valve. So there was a concept of actually using a larger device as the second one. We decided to go to the lab and to do some tests with several different sizes of Venus P valve, but we started with 36 and we implanted 34 inside. And this is how it looked in a closed circuit. You can see that the valve was actually closing and opening properly, and there was full expansion of the inner valve. And also what was very important, the effective orifice area was large, and there was a regurgitation fraction of less than 10%, but that was both through the center of the valve or perhaps around the valve. And there was no migration observed. So this is one of the scenarios that can happen for Venus P valve. Let's say now we have the same patients coming back to cath lab for a third valve. So as you know from previous papers, within SAPIEN, another 29 can be implanted, or maybe 26, and that would expand better. If we think of Venus P valve, we can go for 32. And that's what we did in the lab. We tested these three devices together. Effective orifice area was maintained, and the regurgitation fraction was even less. So valve number 4, we can play with that for a slightly longer time. So this time, I guess 26 for the SAPIEN valve would be the biggest one. For Venus P, we can speculate maybe 30 millimeter or maybe 29 balloon expandable valve. Is that a common situation? So according to knowledge I have, there were more than 3,000 implants worldwide with Venus P valve. And I know about 2 cases of valve and valve, the 2 that I shared with you. So not many cases really need that for the moment. But on the other hand, if you think about the sizes, so worldwide, actually 36 is the most commonly used, followed by 34 and 32, and they all are compose more than 75% of valve use. So these patients will need some other ideas how to tackle these large housings. We tested these combinations, Venus P and Venus P, Venus P without the distal flare and without the proximal flare, and finally balloon expandable valve. I mentioned these results already, so now I want to focus on these combinations. You can see there is a Venus P without a distal flare and straight valve. So similarly, effective orifice area is maintained and above the benchmark, and regurgitation fraction is still single digit. If you look at the balloon expandable valve, let me go back here. We tested 29 into 32, and we had the lowest regurgitation, and effective orifice area was also pretty good. So next step was to try to see if these combinations are stable. So on the left side, you can see 28 millimeter valve in 36 millimeter Venus P, and obviously there is migration even under lower pressure. That's pressure in the pulmonary side of the valve. If the pressure goes higher, so in hypertensive situation, obviously the valve is not stable. But if we go with 30 millimeter valve within 36 at the regular pressure, there is no migration. But in hypertension situation, there will be migration. And from these results, we can learn that if you implant a 32 millimeter valve into 36, you should have no migration, both in low and high pressure situation. So from this, taking this experience to cath lab and together with silicone model and the simulator, which actually allowed us to implant multiple devices in different scenarios. We started with the 36 millimeter Venus P and then followed it with 34, 32, 30, and 29 balloon expandable Vita. So that was first sequence, and the second sequence was actually to implant 28 millimeter Venus P, and within that complex 26 millimeter balloon expandable Vita valve. Several lessons learned there, that long sheath dry seal was not really needed. There was smooth introduction in all these cases, and we started deployment with the alignment of the distal flare, which is actually quite helpful. Once you have aligned the distal flare, then the remainder of the implantation is rather straightforward. Importantly, there was very little under expansion of the inner valve, less than 2 millimeters from the nominal size. So for example, if we implanted a 32 millimeter valve, tubular section of that valve measured just above 30 millimeters. So it was almost completely expanded. And when we implanted a balloon expandable valve, there was very minimal recoil during balloon deflation. And that's important because the more nitinol you have there and the more leaflets tissue, everything can be stiffer. So this actually shows that despite having 4 valves there was minimal recoil when deflating the balloon of the balloon expandable valve. And that was confirmed in measurements of the tubular section, both of the nitinol valves, so self-expanding valves, and the balloon expandable Vita valve. The outer diameter, what is also very important, did not increase. So here we have complex of 4 valves, self-expanding valves, and inside is the 5th one. But the outer diameter still is 30 less than 36, which is very important to avoid compression on the nearby structures. And the inner diameter of the balloon expandable valve was close to nominal, so 29 in this scenario. And now just to summary these experiences, so valve and valve has been bench tested or performed in patients with most of self-expanding platforms. But there are very different concepts. Some valves need to be expanded, so then there needs to be tests performed to see if there will be compression on the nearby structures, whereas for a large housing of self-expanding Venus P valve, it's rather occupying the space inside and not making everything larger. Risk of coronary compression and ascending aorta is different for these devices. So if you need to stretch, expand valve complex, obviously it's going to be higher. And if you just go and work inside the original valve, the risk is lower. So with the technologies that we have right now, we could consider tetralogyophallo patch repair as a palliative surgery that prepares a patient for a lifelong percutaneous treatment of dysfunctional RVOTs. And looking more specifically at the large housing, so this large diameter actually gives us more flexibility for future valve-in-valve implantations. These scenarios were the most optimistic, but sometimes we can have some calcifications of leaflets, or maybe part of the valve is not fully expanded. So depending on the anatomy and the shape of the first venous P valve, you can make a decision if you want to go for a series of self-expanding valves, or maybe you want to put a large balloon expandable valves, and there are valves available like 34 millimeters. But the goal is actually to minimize patient prosthesis mismatch. And with this large housing, I think it can be quite easily performed. And also, the valve-in-valve implantation can be simplified. In cases presented here with venous P valve, there was no need to do balloon dilation of leaflets, but and for some patients in the future, that might not be needed. But even if it is, it will require less balloon inflation and less hemodynamic instability when compared to other platforms that reduce dimensions of the outflow tract. And finally, if you do not expand the tubular section, so the first valve, the outer valve, is the maximum diameter that you have in the outflow tract, so you can assume that there will be very low risk of aortic or coronary compression. So now I just want to say thank you very much to several people, Sir Shaq, Warakan, Damien, Jacek Kusa, Job, and the Venus team for supporting this concept of valve-in-valve implantation. Very recently, we performed animal tests, and we have plenty of data. Hopefully, this year we'll have many opportunities to share that, discuss, and right now I'm happy to hear what other people would do in these situations, and if maybe there are other experiences of valve-in-valve implantation with self-expanding platforms. Thank you very much.
Thank you.
Thank you very much, Sebastian. Very interesting, and I mean, it shows that probably we can keep the patient for a long time out of surgery. Are there any questions?
So, Mark, we've got about 5 minutes left for the webinar, and so just a couple of quick questions or comments. One is really addressed to Francisco. Francisco, you've had some fantastic up to 10-year follow-up. So let's say your patients, the valves that you put in South America last for 10, 15 years. Essentially, what Sebastian is telling you is that in the future, you will not need any further surgery, I emphasize, because valve-in-valve should get you through the rest of the patient's life. Is that a fair assumption at this stage?
Yes, for sure. I would like to thank Sebastian for that information, but I have been waiting for that. I assume that I will be able to do no less than 4 valve-in-valve procedures in the future.
And Sebastian, again, you were doing experimental work, but clinically, having got a venous valve in place, let's say a 36 or a 34, technically, the rest of the procedure is easy, isn't it? Is that fair to say, next time you do a valve?
Well, Shaq, for I guess many patients, yes. It also depends on what happens with the leaflet. So the tests I've done, all the leaflets weren't calcified stiff. So maybe some patients will actually require some balloon dilation. And as we know, sometimes valves are maybe a little bit underexpanded. But I think this large platform gives you a lot more options. You can go with self-expanding, or you can go with balloon expandable if we need more force.
Yeah. Okay. Mark, we've got 4 minutes. So do you want to summarize this whole session, and then we'll call it a day after that?
Yeah. Well, I think it have been very interesting presentations. I think the clinical cases, both from Maria, Ahmed, were very interesting of what to do and what not to do and how to think about implantation. Patrice Guérin showed us that we still don't know exactly how to behave with anticoagulation. I saw in his last slide, he said to harmonize things. I think I have an argument for right now not harmonizing things, because otherwise we'll never know. If everybody does the same thing, we will have nothing to compare with. And I remember also the comment from Francisco saying with aspirin alone, he doesn't see too much trouble. Actually, that's the same case that we observe in Belgium. Other people, of course, have observed other things, and I think it will remain a different issue, especially in a rare complication that we are seeing. And then I think the message from Sebastian is also promising. If we do the first implantation good and we allow for a large landing zone, that large landing zone will make future procedures, I wouldn't say easy, but I mean straightforward and very, very predictable, and probably also with a very long-lasting result. It is my prejudice, however, that probably venous valves, the ones we have implanted here, the oldest ones, I almost see no wear and tear on the older ones. So I think probably Francisco in 10 years can come back and speak about his original series and still mention the same patients where there's almost no wear and tear. That's what we hope that he will be doing. I think I wrapped it up rather well.
Yeah, thank you, Mark. Thank you very much indeed for everybody. And just a quick finishing point about the antiplatelets. What we're finding is that, but nobody tests them scientifically, but there are certain racial groups with aspirin resistance. And so if you give aspirin to them, it'll have no effect. And that is another area that we might have to explore. But thank you very much to every single person, attendees in particular, but for spending their day with us. And have the rest of the day or evening or night, have a pleasant evening. Enjoy yourselves. Thank you to Venus as well.
Thank you.
Bye-bye. Thank you very much. Bye.
Thank you to all.
Bye-bye, everyone. Thank you all.
Bye-bye.
Yeah, bye-bye.